All right, let's talk anti-dysrhythmics, one of the most high-stakes topics you're going to face on the NCLEX, but we are going to nail it. So I want you to just picture it. You're in clinicals, you walk into your patient's room, and bam, you see this on the monitor. That, my friends, is ventricular fibrillation. Your patient is totally unresponsive. You can't feel a pulse. We are in a code blue situation. What's the first thing you do? What drug are you thinking of? Because that jagged line on the screen, it's so much more than a tricky test question. It's a real person's life on the line. And knowing these drugs inside and out isn't just about passing your boards. It's about being that nurse who knows exactly what to do when every single second counts. So, before we can even begin to fix a rhythm that's gone completely haywire, we've got to have a solid picture of what a normal one is supposed to look like. Let's take a super quick trip down the heart's electrical superhighway. Just think of it like this. The heart's conduction system is a perfectly timed highway. It all starts with a little spark up in the SA node, that's the pacemaker. That spark zips across the atria, making him squeeze. Then it hits a little traffic light at the AV node, pauses for just a beat, and then boom, it races down through the ventricles. That final jolt is the big one. It's what pumps blood to the whole body. A dysrhythmia? That's just a major pileup on this highway.
And how do we actually see what's happening on that highway? With this, the EKG. It's like the heart's own secret language. Now listen, you do not need to be a cardiologist for the NCLEX, but you do need to know the basics. That first little bump, the P wave, that's the atria doing their thing. And that big spike, the QRS complex, that's the main event, the ventricles firing. It's what you feel when you check a pulse. And when this beautiful pattern goes all chaotic, well, that's our cue to step in.
Okay, you ready? Let's get to the good stuff. We're about to load up our medication arsenal. These are the tools we're going to use to tackle those crazy rhythms and get that electrical highway back in working order. First up, we've got our Class IA sodium channel blockers. And the poster child for this group is procainamide. So how's it work? Simple. It blocks the sodium channels. What that does is it slows down that electrical signal zipping through the heart. It's literally like throwing down some speed bumps to calm everything down. Okay, NCLEX alert, this is huge. You're giving IV procainamide and you look up at the monitor, the QRS is getting wider and wider and their blood pressure is tanking. What is the very first thing you do? You stop that infusion. You have to stop the problem at its source. That's Nursing 101, and the NCLEX absolutely loves to test it. Moving on to our next class, beta blockers. The easy memory trick here is they all end in lol. Think propranolol. What do? Well, they block the beta receptors, which are part of your fight or flight system. So, by blocking that system, you're essentially telling the heart, hey, chill out. And what happens? The heart rate slows down and the blood pressure comes down with it. So it's just common sense, right? If these drugs slow everything down, what's your number one priority? Vitals. You have to check those vitals before you ever give the dose, and you need to know the numbers. So burn this into your brain. Hold the med if the heart rate is less than 60 or if the systolic BP is under 90. And here's another classic NCLEX trap. Never, ever let your patients stop these cold turkey. They have to be weaned off or they could have a massive rebound. All right, let's talk about one of the big guns, amiodarone. This is what we pull out for the really scary rhythms. We're talking VTAC and VFib. Its whole job is to block potassium channels. This makes the heart muscle way more stable and a lot less, well, irritable. It's a lifesaver, for sure. Now listen up, because if you remember one thing about amiodarone for your test, this is it. The number one, top of the list, high priority side effect is pulmonary toxicity. I'll say it again, pulmonary toxicity. So what does that look like? Your patient suddenly has this new annoying dry cough, or they're getting short of breath. That is a massive red flag. You cannot ignore that. Okay, on to our class 4 drugs, the calcium channel blockers. A common one you'll see is verapamil. And just like the name says, they block calcium channels. They mostly do this at that AV node, that little traffic light we talked about. By doing that, they slow the whole signal down, which really helps to calm down fast rhythms like SVT or AFib. And hey, are you seeing a pattern here? I hope so. Just like the beta blockers, these guys slow the heart down and drop the blood pressure. So what's your priority? Yep, checking those vitals. And the rules are the same. You hold that dose if the heart rate is under 60 or the systolic is under 90. Seriously, just knowing those numbers is going to score you some easy points on the NCLEX. All right, Let's wrap up our meds with two special players that don't fit neatly into the other classes. First, we have adenosine. I love this one. It's literally the Control-Alt-Delete for the heart. You push it and it just stops everything and lets the heart reboot. It's amazing for SVT. And then you've got magnesium, which is the one and only go-to drug for a very specific, crazy-looking VTAC called torsades de points. Okay, for adenosine, the NCLEX isn't just going to ask what it does, they're going to ask how you give it. And the answer is fast, like a 1 to 2 second slam, immediately followed by a big saline flush. You also got to tell your patient, hey, you're going to feel really weird for a second. And then don't panic when you see a flat line on the monitor. It's supposed to do that. For magnesium, your keyword is toxicity, and the classic first sign, they lose their deep tendon reflexes. That's your clue. All right, we've gone through the meds, we've covered the safety alerts, now it's time to put it all together. Let's run through a quick NCLEX-style scenario and see if you can pick out the priority. Okay, here we go. Your patient is getting IV procainamide. You notice their QRS is getting wider and their blood pressure is dropping. What is the nurse's priority action? A, B, C, or D? What are you going to do first? Take a second and really think about it. And the answer is B, stop the infusion. Did you get it? This is pure NCLEX logic. When something is actively harming your patient, your first move is always to stop the thing that's causing the harm. So you hit pause on that pump. Then you can assess, then you can call the doctor. But step one is always to stop the harm. Nail that down and you'll crush priority questions. Okay, deep breath. Let's do a super fast 60-second review to really cement all this in your brain. This is your ultimate cheat sheet. You ready? Let's go. Procainamide, your priority is stopping for a wide QRS or hypotension. Propranolol, you're holding for a heart rate under 60. Amiodarone, the big one is pulmonary toxicity, watch for that cough. Verapamil, same deal as propranolol, hold for that heart rate under 60. Adenosine, you gotta push it fast and expect that flatline. And magnesium, monitor for toxicity, starting with those reflexes, and remember your antidote is calcium gluconate. Boom, done. You've got this. So look at that. We started with a scary-looking rhythm, and now you're armed with the knowledge to handle it. You know the meds, you know the biggest safety alerts, and you know how to think like a nurse and prioritize. So the next time you see that monitor going wild, are you ready? Yeah, you are.